Thanks, Dr. Vella. So thanks for having me, and thanks to the Our Baby Foundation for funding this very important day. So I started getting really excited about lower respiratory tract infection during my chief year when I was attending on the wards in Philly, and basically seeing these kids with bronchiolitis and getting frustrated by the fact that we had nothing to do for them other than wait and wait it out and see how they did. And so that sort of the lack of evidence behind that management really got me interested, and that's when I started designing my fellows project, which was a randomized trial of using nebulized hypertonic saline for bronchiolitis in the emergency department setting, which we found did not work. But yet another thing to add to the list. So I think what that did for me, though, is it also opened my eyes to the fact that bronchiolitis and pneumonia are common. They are extremely common. And yet the amount of evidence, strong evidence that we have regarding their management is actually quite low when you think about it. We have not found many things that work, and there's a huge amount of variation. So worldwide, and I don't know how many of you know this, but pneumonia is the leading killer of children worldwide. It kills more children than measles, malaria, and AIDS combined. So it is, the worldwide burden is huge. Now, in the United States and in developed countries such as the US, we're actually pretty fortunate because we recognize it early and we don't have malnourished kids for the most part, and we are able to treat it effectively. However, despite the fact that our mortality rates remain quite low, the prevalence of pneumonia and bronchiolitis remains quite high, and the potential morbidity that comes from the complications of pneumonia is actually on the rise. So if you this study by Ron Caron was published in 2012, and it looked at the prevalence and cost of pediatric conditions for pediatric inpatient conditions. So as you can see here, pneumonia is ranked second in cost and fifth in prevalence of all pediatric conditions that we hospitalize kids for. So it's quite common. In terms of cost, you can see there the cumulative cost in millions is basically $2.1 billion per year that is spent on pneumonia care in this country annually for hospitalized kids. So I want to start with these two cases, and there's some similar and some different, and just ask for a few questions. I couldn't get the audience response thing to work on my PowerPoint, so I will do it the old-fashioned way with a show of hands. So first case, 12-year-old boy, 6 days of cough, chest pain, fever to 102, comes in, his respiratory rate is 24, his saturations are 93%. He has a diffuse wheeze with a history of wheeze as a distant wheeze as an infant, and you note right posterior orals on your exam. Okay, how many of you would get a chest x-ray? There's no right or wrong answer. Good. How many of you would treat with antibiotics without a chest x-ray? Okay, good. How many of you would treat with amoxicillin, azithromycin, a smattering of hands, ceftonir, clindamycin? Okay. So there's
another option, get the chest x-ray, but treat regardless of the findings of the chest x-ray.
Okay, so we'll talk. Right, exactly. So the next case is an 18-month-old girl. Okay, so we're now dealing with a toddler, infant toddler, 3 days of cough and congestion, fever to 102, breathing at 56, SATs of 92% on room air, diffuse coarse wheeze, coarse rhonchi, did wheeze once at 6 months of age, and has right posterior orals on your exam. How many people would get a chest x-ray? Did I hear lung ultrasound? Is that what I heard? Man, you guys need your ultrasound at this institution. Oh, we'll talk about that. Okay, good. So ultrasound aside, okay, so I got a smattering of hands with chest x-ray. How many people would, okay, so you get a chest x-ray, atelectasis versus infiltrate. How many people would treat with antibiotics? Okay, good. So there's a little smattering of things here and there. So these two cases, you have suspicion for, the main question that you have is this community-acquired pneumonia or not? And that leads to a whole host of questions. Is it viral versus pneumonia? Do you get a chest x-ray? Do you get an ultrasound? Oh, see, I spent the whole plane ride working on this animation. There we go. Chest X-ray, ultrasound. Do you get a CBC, CRP, procalcitonin? Do you get a blood culture in these kids? Test for viruses. Is it due to bacteria, viral, atypical causes? Do you give antibiotics? Do you give ampicillin? Do you give ceftriaxone? Do you give azithromycin? Do you admit them? Thank you very much. And that just leads to one big question mark, because there's all of these questions around what do we do with these kids, and the bottom line is the answer is difficult. There's challenges. How do we define pneumonia? Is pneumonia a clinical diagnosis or is it a radiographic diagnosis? How about etiologic detection? How do we determine if a child has bacterial pneumonia versus viral pneumonia versus atypical bacterial pneumonia? How do we make the diagnosis? Do we use an X-ray? Do we use an ultrasound? Do we use laboratory testing? What about therapy? Who do we treat? What do we treat them with? Where do we treat them? And how long do we treat them? And finally, the complications, which we always have to think about because the rates of empyema and pleural effusion are actually on the rise in the United States. And certainly, what do we do with those kids that have a lack of response to therapy? So I hope that in this 45 minutes that we will talk about appreciating these challenges, that I will help you to develop an evidence-based approach to the diagnosis and management of pediatric pneumonia in the ED setting, and finally to review the 2011 Infectious Diseases Society of America guidelines on the management of children with CAP. Just a show of hands, how many people have looked at these guidelines or know of these guidelines? Okay, about a third, that's good. So what I would like to try and do is present you with the latest data. So this was published about a month and a half ago in the New England Journal of Medicine. It was a headline article about the etiology of community-acquired pneumonia in kids. This study looked at over 2,000 kids at 3 pediatric institutions funded by the CDC as part of the CDC's EPIC study, the etiology of pneumonia in the community study. Now what they found, the first bar here, is all of the children in the study, and then they split it by age, less than 2, 2 to 4, 5 to 9, and 10 to 17 years. So, overall, the blue shaded boxes show you viral infection, single virus and viral co-detection. So 65% of pneumonias overall have a virus, one or more viruses detected. And what you can appreciate is that the younger the child, the more likely it is to be a viral etiology. Kids less than 2, 80% of these kids had a virus identified, whereas that number goes down to about 35% in the adolescent population. Now keep in mind that this is about detected pathogens only. So the most common bacterial cause of pneumonia in kids is Streptococcus pneumoniae, very difficult to detect when it's focal in the lung. So this sort of splits up your organisms by age group. And what you can appreciate is the young kids, your RSV in red and your human rhinovirus in blue are your most common, and now we've recognized over the last decade or so human metapneumovirus as an important cause of viral pneumonia. And your pneumococcus and your mycoplasma, which are green and yellow, are pretty small slices of the pie. But as you get into school age and adolescence, all of a sudden, mycoplasma becomes the most commonly detected organism in pediatric pneumonia. Now, there's this small piece of the strep pneumo pie. I would say that it is true that pneumococcus has declined significantly with the introduction of first the PCV7 and then the PCV13 vaccines. However, we still have trouble detecting it, and I would argue that probably pneumococcus still plays a pretty prevalent role in pediatric pneumonia, particularly in the school-aged and adolescents. So the trouble with sort of etiologic testing and the lack of sort of strong evidence has led to a significant amount of variation. So this was a study that we performed during my master's, where we looked at 36 freestanding pediatric hospitals and in the ED and looked at who was doing what types of tests. And the lighter boxes mean low utilization, and the dark boxes mean high utilization. And so the hospitals were grouped into these low, moderate, and high overall utilizing groups. And as you can see from this heat map, if you use more of one test, you use more of every test, just about. So the high utilizers cluster together. So first of all, there's huge variation across the country in how we're caring for these kids. Second of all, the major finding from this study was that these high utilizers also hospitalized their kids significantly more than these. However, These low utilizers did not have more ED revisits. You would think, well, if they're not hospitalizing these kids, well, maybe they're missing some diagnoses. And we actually found that they did not have increased revisit rates. Revisit rates were stable across the board. So the thought is higher utilization leads to more hospitalization, possibly unnecessary hospitalization because of the results that we're seeing of our testing here. So what's the big deal? What's the big deal if we just give them some amoxicillin? What's the big deal if we just get a chest x-ray? So this 18-month-old that I talked about with fever and cough, well, you get a chest x-ray. Atelectasis versus infiltrate. Okay, I'm going to treat them with amoxicillin because I don't know if it's bacterial pneumonia or not. Uh-oh, they come back 3 days later, they still have a fever and cough because it's probably a viral illness, but they still have a fever and cough, so they get put on Augmentin, sort of like the otitis pathway. Fine, they get put on Augmentin, then they come back in 2 days, they have a rash, and they're still coughing. So now, uh-oh, is this an allergy to Augmentin? They get put on Ceftonir. Let's step it up, 3rd-generation cephalosporin. Uh-oh, they're back in another day because they've got bloody diarrhea, Omnicef poop, and they're coughing. So, but we don't recognize it as Omnicef poop because, and there's some concern, so we get a CBC, and the white blood cell count is 29,000. Now we got an elevated white count, a kid with prolonged symptoms, he's been on 3 antibiotics, the parents are fed up, the white count is high, something bad must be going on, let's admit him, and then ultimately we all feel like this. So this is an exaggerated story, but I would venture to say, because I see this sort of thing on a regular basis, and I would venture to say that everyone in this room has seen this on a regular basis, where one test or one treatment leads to another consequence and another consequence, and then we're left sort of, wringing our hands. So in an attempt to minimize this variation, the IDSA and the Pediatric Infectious Disease Society published these guidelines for the management of community-acquired pneumonia in infants and children older than 3 months of age. So I'm going to take you through 4 key decision points as we manage pediatric pneumonia in the ED, from the start of the visit to the end of the visit. I'm going to share with you the evidence, I'm going to share with you some guidelines, and hopefully give you a practical approach. So, decision point 1, does the kid have pneumonia? Okay, so that's sort of the most important thing to know right up front. This was just published, hot off the press, March 2015, Lancet Infectious Diseases. Clinical features for the diagnosis of pneumonia in children younger than 5 years. They did a systematic review, they did a meta-analysis. And what did they find? Not one clinical feature was sufficient to diagnose pneumonia definitively. Combinations of clinical features in a decision tree might improve diagnostic performance, but the addition of new point-of-care tests for diagnosis of bacterial pneumonia would help to attain an acceptable level of accuracy. Okay, and here's what they found. These are the pooled likelihood ratio positives and likelihood ratio negatives. I always like putting a little bit of evidence-based medicine into my talks, so it's going to be on all of your boards, so let's review. Likelihood ratio positive is the likelihood of a positive test in a patient that has the disease over the likelihood of a positive test in a patient that doesn't have the disease. Likelihood ratio, what it does is it tells you how much your pretest probability will be altered by the addition of that test being positive. If your likelihood ratio is 5 or 5 to 10, you've got a moderate amount of change of your pretest probability to your post-test probability. If it's greater than 10, that is a significant change. So a likelihood ratio of 1 means no change. So all of these likelihood ratios, tachypnea, grunting, retractions, flaring, they all were right around 1.5 to 2. Not great. And then your likelihood ratio negative. So that's the likelihood of negative disease, of a negative test in those who don't have the disease, divided by the likelihood of a negative test in those who have the disease. So this is basically ruling out. 0.1 or less is an awesome negative likelihood ratio. And here, cough is 0.3, which comes pretty close to that in terms of if you don't have a cough, your likelihood of pneumonia is fairly low. But fever and tachypnea or lack of tachypnea don't really help you, okay? So we get to clinical prediction models. There have been several published. We're working on one ourselves. There have been several published over the course of the literature. What you will notice is that many of these features show up in multiple models. So I think we can extrapolate from that some combination of these symptoms would give you a higher likelihood of pneumonia. The first is fever. And that being said, I can tell you, in our own study, we've seen some pretty severe pneumonia without fever, which is why fever is not in all the rules, and I would not use that as your definitive. Crackles or ralls. Tachypnea. And I want to spend a second on tachypnea. So remembering pediatric vital signs, particularly for the general emergency medicine practitioners in the room, it's always a little bit sort of daunting what really is tachycardia, what's tachypnea based off of the ages. I use the 60-50-40 rule. It's what the WHO uses. It's easy to remember. If they're 2 months or less, they're breathing 60 or more, they're tachypnic. If they're 2 to 12 months, 50 or more, they're tachypnic. If they're 1 to 5 years, 40 or more, and then 5 to 12 years, 20 or more. And then you hit adult ranges for adolescents. That's sort of the easy way to remember it, okay? Now, when we look at the data, the positive predictive value of tachypnea is 20% and the negative predictive value is 88%. So negative predictive value, that is the proportion of kids that have a negative, the proportion of kids with a negative test that do not have the disease. So that's 88%, which means that children with pneumonia, 12% may have a respiratory rate that is not in the tachypnea range. So it's less sensitive and specific in the first 3 days. It's most sensitive in the toddler age group. So just something to keep in mind. The other thing I'll say about tachypnea, how do we get our vital signs in the ED? We all do it. I do it. We sit there and we count for 10 seconds and multiply by 6, or we count for 15 seconds and we multiply by 4. Not accurate. Not in an infant or a toddler. They've got periodic intermittent breathing. You've got to sit there. I sit there for a full minute. I look at the clock and I count them for a full minute. It's a painful 1 minute, but that is the accurate way to. That is the way to do it. So then the last thing is hypoxia, and you can see by our different rules that our cutoffs have ranged anywhere from 92 to 96%. So what if our patient was wheezing? So this is a really interesting question. There's not been a lot of work on this area. The one study that was done by Matthews out of Boston Children's found that the rate of pneumonia was very low in wheezing children that did not have fever. And that the factors that were associated were fever, abdominal pain, and an oxygen saturation less than 92%. 20.6% of kids in this study had radiographic pneumonia that were febrile and hypoxic at that 92% cutoff. I just presented this work at PAS, actually yesterday morning, and this was at our institution. We looked at 14,000 kids with an asthma exacerbation in our ED at Cincinnati Children's over 3 years. 34% of these kids received a chest x-ray. However, radiographic pneumonia was only present in 6% of the cohort. So we tried to figure out what factors in kids with asthma exacerbations are associated. And as you can see, your likelihood ratio positives and negatives are not great for single signs, with the exception of potentially your oxygen saturation where you have a dose-dependent response. However, the combination of fever and an oxygen saturation less than 92% had likelihood ratio positive of 4.3. So good for ruling in, but the likelihood ratio negative is 0.98, bad for ruling out. So we cannot use these clinical signs or symptoms to rule out, which is highly frustrating. So keep your eyes peeled. Hopefully we'll get this thing published by the end of the year, and hopefully it'll come out in some amazing journal. So the summary is, when we look at the IDSA summary for wheezing, here's what the guidelines recommend. If a wheezing child is not febrile and not hypoxic, no chest x-ray. If you should consider a chest x-ray with fever, hypoxia, and abdominal pain based off of low to medium quality evidence. And that's important to remember. So what about the best imaging modality? And clearly chest x-ray is our go-to, right? So is our gold standard really copper? So when we look at, there have been multiple studies that have been done looking at chest x-ray and how well we read chest x-ray and how well we agree on chest x-ray. So I'm like bringing a lot of statistics in here. Here we go, Cohen's kappa. So Cohen's kappa is the amount of agreement when considering more than chance agreement. So pediatric radiologists, they agree with themselves with a 6-week lag, pretty good, right? 0.8 to 1 is pretty awesome agreement. Senior and junior EM people, they do pretty well with agreeing for themselves, but not as great as the radiologists. Now here's where we all bomb, including the radiologists, is how well we agree with each other or don't. So radiologists and senior EM faculty, we won't put an age limit on the senior EM faculty, have a kappa of around 0.5, which is like, eh. And then the junior PEM people, like myself, we stink at agreeing with each other on chest x-rays. So this is really problematic, and that's part of the challenge, is that we all read these x-rays differently. This study went even further and looked at 6 radiologists and kids with suspected pneumonia. And you can see if there was an alveolar infiltrate, they agreed pretty well, kappa of 0.69. But all of the rest of these, any infiltrate, any of the interstitial, were air bronchograms present, hilar adenopathy, even pleural effusion, radiologists could not get their kappa above 0.6. So chest x-ray is highly problematic, but it's what we have right now as the gold standard. So the recommendation. So the IDSA recommends that we do not obtain chest radiographs in clinical pneumonia who are well enough for outpatient treatment. So this is when you as the clinician feel that the probability of pneumonia is high enough based off of a combination of clinical signs or symptoms. So I would say it cannot be based off of a single sign or symptom. They're coming in with fever, they're tachypnic, they're hypoxic, they have RALS. That's pretty good for clinical pneumonia. It's sort of the best that we have, that combination of 4 signs and symptoms. And so with those kids, if they're well enough to go home, the recommendation is no chest radiograph. Now, I will be the first one to admit that in the ER, where you just click the button and say, go get a chest x-ray, it's sort of, you want to know. Because if the chest, it's a trade-off. If the chest x-ray is negative, you might not treat that child with antibiotics. So the trade-off is, and we don't know the answer to this yet, the trade-off is more chest x-rays or more antibiotics. And I'll just leave that out there because I don't have the answer. I know what my bias is, but I don't have the answer. So what is the recommendation for when we do get chest x-rays? Well, hypoxia, significant respiratory distress, if they're failing initial antibiotic therapy, so if they're still febrile 48 hours after starting initial antibiotic therapy, get a chest x-ray. If you suspect complications, a pleural effusion, a pneumothorax, all hospitalized patients should get chest x-rays. And the rationale behind that is if they're sick enough to come in the hospital, you want to get a baseline so that if they get worse and they develop an empyema, you want to have a baseline chest radiograph. Or if they're sick enough to be hospitalized, do they have an empyema, and how large is their effusion? And then if the equivocal diagnosis. So if you're not sure that you're dealing with pneumonia, based off of your clinical signs or symptoms, I think it is reasonable to get a chest x-ray. So what about ultrasound? I know that this institution is the king of POCUS in the ED. So this was a meta-analysis that was just published again. I think this was like last month, hot off the presses. And what this found was the negative likelihood ratio pooled was 0.06, and the positive likelihood ratio pooled was 15.3. So ultrasound is looking pretty awesome here. Here's my problem with it. All of the studies that have been done have been the standard, this is the sensitivity, this is the specificity of ultrasound. There has been no study that has actually looked, that I know of, that has looked at actually the clinical outcomes. So if you look at some of the studies, ultrasound for infiltrates greater than 1 centimeter is about equivalent to chest x-ray. However, ultrasound is better to find consolidations less than 1 centimeter. However, I don't know what a 5 millimeter consolidation means in a child that you don't see on chest x-ray. So until we know the meaning of that, I don't think we're ready to say that lung ultrasound is the new way to diagnose pneumonia. I don't think we're ready to say that, and I am not convinced that the evidence is strong enough. I know that's a little controversial in this room, but that's, I think, where the evidence is right now. It may turn into the gold standard once we have some clinical outcomes. So, third decision point, laboratory testing. Okay, we love the CBC, right? So, the white blood cell count, traditionally thought to be the marker of bacterial infection, seg predominance, left shift, it has poor specificity for bacterial pneumonia. We know that right now. We know that the degree of elevation does not distinguish viral from bacterial etiology. Because of these 2 key facts right now, the recommendation is to not routinely obtain a CBC in most kids, the majority of kids with community-acquired pneumonia. If they are sick enough to go to the ICU, if they are looking septic, to Benita's talk, then it may help you. Why? Because there's a few things that you can get from a CBC. 1, the rare case of pneumococcal HUS, which is a known complication of pneumococcal pneumonia. 2, in kids with multifocal pneumonia, you're going to be thinking much more of MRSA, community-acquired MRSA, if you see a multifocal pneumonia. If you see a leukopenia, If your white count is low, your ANC is low, in kids with a multifocal pneumonia, that is a huge red flag. You need to treat those kids aggressively. So, if I see a multifocal pneumonia, severe disease, I'm getting a CBC because of those two factors. Not because I want to know how high the white blood cell count is, not because I want to know what percent neutrophils. So that's important to know. Acute phase reactants, CRP, ESR. These do not reliably distinguish bacterial from viral, and therefore we do not routinely obtain. However, like the lactate in sepsis, some institutions like to obtain a CRP in hospitalized kids so they can trend resolution. Not unreasonable, but I can tell you at our institution we do not obtain CRPs on any of our hospitalized kids with pneumonia. We don't find them very useful. It's a clinical, you follow them clinically. Now, what I did not include there was procalcitonin. So some of our work at Cincinnati Children's and some other groups are looking at the utility of procalcitonin to differentiate etiology and severity. More to come on that. I didn't include it in the talk because we don't really have enough data yet to draw conclusions on it. So what about blood cultures? So blood cultures are currently one of our only ways to be able to actually detect a bacterial etiology in pneumonia. The problem is that pneumonia is often so focal to the lung that we don't have hematogenous spread. So the yield of a bacteria in pneumonia is less than 2% in outpatients and ranges from 2 to up to 10% in inpatients with uncomplicated pneumonia and 15 to 25% if you have effusion or empyema. So it may alter your treatment plan if positive. So the recommendation is do not routinely obtain. However, consider in hospitalized patients with moderate to severe disease or complicated pneumonia, defined as abscess, necrosis, effusion, empyema. I will tell you that at our institution, we obtain blood cultures on every child that's admitted because of some work that we did when I was a fellow that found that actually of positive blood cultures, 80% of the time it changed the management when we did see a bug and we saw susceptibilities. So there is a lot of, it's still a little controversial, there's a lot of work to try and decrease unnecessary blood culture use as well. I would say if they're sick enough to come in, get the blood culture, particularly if your institutional contamination rates are pretty low. Ours are. So we get them on everyone. What about viral testing? The guidelines recommend rapid diagnosis of influenza with a sensitive and specific test during an influenza epidemic should be used because it can decrease additional studies in antibiotics and guides appropriate use of antivirals. So if there have been now multiple studies that have shown that if you have a positive flu test early in the hospitalization, early in the ED visit, that those kids will get less diagnostic testing later, their length of stay in the ED will be shorter, and their cost is lower during influenza season. And the guidelines say that antibacterial therapy may not be necessary if you have a positive flu test and no findings of bacterial co-infection. So if you have a positive flu test, but you've got focal RALs, hypoxia, and then because of the hypoxia, you get the x-ray and there's a focal consolidation, I would still treat that child with antibacterials. I would not rely. But for the kid with rhinorrhea, positive flu test, young age, flu epidemic, no focal findings, antibacterial therapy may not be necessary. And then other viral testing may modify clinical decision making in certain settings, and that they sort of left that as a low quality evidence and a weak recommendation. So here's the future. This is the stuff that I think is like so cool. It's like the Star Trek of pneumonia diagnostics. Okay, so this figure B, this is, and I just show this to you because I think it's cool, and this is, I think, where the future of infectious disease diagnostics is going. Okay, so this is a microarray looking at genes on peripheral blood leukocytes, so whole blood. It's looking at RNA, and what the green is influenza, the red is Staph aureus, the purple is strep pneumo. Okay, red is overexpressed genes, blue is underexpressed genes. And even an ER doctor like myself can look at that and say, oh, they look different. Gene expression is different between influenza and strep pneumo. So these sorts of microarrays, I think, are going to be the future of where we're at. This is the only thing that we got right now to sort of differentiate. This is looking at urine. Metabolites in the urine. This study found in adults with respiratory illness that the metabolites that are excreted in the urine can actually differentiate with 96% accuracy strep pneumoniae infection from viral infection in adults. And our team, we have some preliminary data. We're pursuing this actively, trying to see if we can find a urine signature, non-invasive, to be able to differentiate bacterial from viral disease. So anyway, keep your eyes peeled. So the summary of the evidence for diagnosis. No single sign or symptom predominates. Combinations of symptoms may be helpful. Hypoxia, fever, RALS, and tachypnea. Chest x-ray is not ideal, and evidence for ultrasound is evolving. And most laboratory testing is not helpful with the exceptions of a rapid flu test during flu season and blood cultures for your hospitalized moderate to severe patients. Okay, so what is the best way to treat these kids? So these are the factors we all consider when we think about treating kids with antibiotics. So age, I already told you viral infection more likely in the younger kids. Epidemiology, what season are you in? Are you in flu season? Are you in RSV season? What's the prevalence of these viruses in your community? Radiographic features, again, they're sort of weak evidence, but sort of all we have. Vaccination status, fully immunized versus not fully immunized. That's gonna alter your decision course. I always ask, this is one of the key questions I always ask the residents when they precept with me is, what's the immunization status? Because it's in my mind that's gonna alter my decision about do I treat with antibiotics and what antibiotics do I treat with and how severe the illness is. I think that this is a situation where antibiotics may not be necessary. Preschool age child, less than 6 years, they have upper respiratory signs, and you have diffuse findings regardless of whether an alveolar infiltrate is present, assuming that they're well appearing and there's no pleural effusion. We don't have strong evidence to be able to say definitively you should not treat them. I think right now that's why I underlined the may, because this is a situation where I think we can start to decrease our antibiotic utilization. Now, this study looked at 29 pediatric hospitals and what antibiotics they use. Now, what you can see, this was pre-guideline. The blues are cephalosporins. There was a lot of cephalosporin use, and the penicillins were the greens, and not a whole lot of penicillin use pre-guideline. What you can also appreciate is, again, huge variation based off of certain hospitals. I think, CHOP, I think this was CHOP. We used a lot of ampicillin even before the guideline. I think at Cincinnati Children's, I think this was Cincinnati Children's, they used a lot of cephalosporins before the guidelines. It was all over the place. So I'm going to try and provide you the guideline-based recommendations. So strep pneumoniae is still considered the most common bacterial pathogen, even though Mycoplasma pneumoniae is the most commonly detected pathogen in the older kids and adolescents. This is most likely to result in serious sequelae, so therefore we treat for it. Amoxicillin is your drug of choice. More favorable pharmacokinetics than penicillin, and the recommendation is high dose, 90 mg per kg per day in 2 to 3 divided doses. Okay, what if they're allergic to amoxicillin? That's actually the next slide. So these are the overall recommendations. For the infant and preschool age kids, and I realize that this is going to cause a lot of angst, and I don't blame you. Antibiotics are not routinely required because viral pathogens are most prevalent. Strength of the recommendation is strong, the evidence quality is high. This is not me, this is the IDSA national guidelines. This does cause me a little bit of angst too. To say, okay, I've got a kid with pneumonia and I'm not going to treat them with antibiotics, even though I can't really detect whether it's bacterial or viral. I think this is where a lot of our work needs to happen with shared decision-making with the parents to try to decrease our unnecessary antibiotics. Now, if you are going to use antibiotics, amoxicillin is first line if they're healthy and fully immunized because of its great strep pneumoniae coverage. If they are not fully immunized, the recommendation is to go to a third-generation cephalosporin, okay? School-age kids, amoxicillin is going to be your first, but you consider your atypical pathogens. Azithromycin is for treatment of older children with findings caused by atypical pathogens, and we'll discuss that in a second. So what are some alternatives? Second and third-generation cephalosporins and clindamycin, they're pretty adequate, but they're adequate usually, depending on your community, against 60 to 70% of pneumococcus. So they're not as good as amoxicillin in terms of being able to give you good pneumococcal coverage. Levaquin, levofloxacin, and linezolid, these are alternatives. However, in the younger kids, you want to stay away from levofloxacin for the toxicity concerns, and linezolid is wicked expensive. So if you're going to make these choices, I would do it after you think about cephalosporins and clindamycin. Now, macrolides, azithromycin. The problem with macrolides is there is a lot of macrolide resistant. Macrolides actually select against resistant organisms on the mucosal surfaces. And where do most pneumonias in kids come from? The mucosal surfaces. So what I would say is treating with macrolides alone, particularly in the younger age group, is not a good idea and should be considered after cephalosporins and clindamycin. For inpatient IV therapy, ampicillin or penicillin G, in our institution it's ampicillin, is your first go-to. You give this in the fully immunized kid. You don't have a substantial high-level penicillin resistance locally. If you know that it's MSSA, you can consider oxacillin or nafcillin. You can give a third-generation cephalosporin. I would limit that to the kids that are not fully immunized, if you have high levels of penicillin resistance in your hospital or community, or if it's a life-threatening infection. If you suspect Staph aureus, if it's a multifocal pneumonia, if you've got a big effusion, if you've got abscess or necrosis, then you're going to want to add vancomycin or clindamycin, not replace with vancomycin or clindamycin. And then a macrolide should be given in addition to the beta-lactam for suspicion of Mycoplasma and Chlamydophila pneumoniae, not instead of for the inpatient child, and we'll talk about that. So this was a Cochrane review in 2012 that looked at, can we predict which kids have atypical pneumonia? And interestingly enough, I was always taught if they wheeze, if they have diffuse wheeze, that's associated with atypical pneumonia. Well, this meta-analysis found that actually the absence of wheeze and the presence of chest pain were associated, but with really not great pooled likelihood ratios. And the conclusion of this is that Mycoplasma pneumoniae cannot be diagnosed with clinical signs or symptoms. That evidence aside, I would say that if you've got a kid that has, an older kid, school-aged adolescent that has chest pain, sort of indolent signs and symptoms, diffuse findings, those are the kids that I'm actually more suspicious for an atypical organism as opposed to pneumococcus. So is pneumonia a sign of vitamin Z deficiency? So, I see Zithromax being given out left and right. I mean, kids come in on Zithromax, they got snot coming out of their right nostril, they get Zithromax. So let's talk about the treatment of atypical pneumonia. This Cochrane review looked at 7 studies, almost 2,000 kids. There was no difference in the clinical response in kids that received macrolide versus non-macrolide. Their conclusions are sort of the way that some of these Cochrane conclusions are, which is there is insufficient evidence to draw conclusions, and that you should balance use with adverse effects, and there's a need for high-quality trials in children. So, where does that leave us? Here's the IDSA recommendations. If the kid is coming into the hospital and they're school-aged or adolescent, and Mycoplasma is a consideration, you should treat them with both a beta-lactam and a macrolide. If you have Mycoplasma testing available, so we have Mycoplasma PCR, I swab these kids for Mycoplasma. I send the PCR because that's going to be back within 24 hours. I stop the azithromycin if it's negative. If it's positive, then that actually can let you finish out your 5-day course of a macrolide. Now for outpatients, here's where it gets a little fuzzy. If atypical pneumonia is a strong consideration, so that sort of clinical phenotype that I talked about, macrolides alone can be considered. However, the guideline really implies doing a combination of amoxicillin with azithromycin because of the potential for pneumococcus to still play a significant role and our inability to strongly rule out Mycoplasma. So what about this situation? So here you've got a whopping left-sided effusion. So this is where ultrasound is awesome. So in order to define it, you get an ultrasound. There you've got some, atelectasis, and here you see a septated, very complicated pleural effusion. So this is the guideline. I don't want to spend, this is the one slide I'm going to spend on it. Here's your algorithm. You see an effusion, okay? You get your chest x-ray. If it is less than a 10 millimeter rim or less than a quarter of the thorax is opacified, give antibiotics. Now, the recommendation is to give similar antibiotics to what you would give without a pleural effusion. I think my own personal practice is because of potential for MRSA with kids with effusions and empyema, rather than start with amoxicillin, I start with clindamycin in the well-appearing child with a small effusion. And then is the patient responding to treatment? Yes? Awesome. No? Then you're going to want to re-X-ray, reassess the effusion size. If it's still small, continue antibiotics and don't drain. But if it's now moderate to large, you pop to the moderate to large effusion here. So a moderate effusion is defined as greater than a quarter but less than a half of the thorax opacified. Then you look at how sick they are. If they're not that sick, you admit them, you treat them with IV antibiotics, or you can obtain your chest x-ray and obtain pleural effusion. I would say that most kids, sick or not, if they've got this large effusion, they're getting an ultrasound. And then if they worsen despite IV antibiotics, then you go to the large effusion algorithm. If you go to the large effusion algorithm, that's more than half of the thorax is opacified. Chest ultrasound or CT, I think the data is clear. Ultrasound is preferred. Don't radiate these kids' chests. Do an ultrasound, see how large it is, see how septated it is, see how loculated it is. Then obtain pleural fluid for culture, drain the pleural space of fluid. Now, if it's simple and not loculated, you can just pop a pigtail in, or you can pop a pigtail in and do fibrinolysis. I actually have a bias against this based off of the literature, or you do VATS, video-assisted thoracostic surgery. Either way, you're consulting your surgery friends. If the fluid is loculated, you have two options: chest tube with fibrinolytics. It fails in about 15%. So the preference that I have based off of basically how I trained in Philly with the surgeons there was proceed directly to VATS. Again, you're getting your surgeons involved regardless. Okay, last decision point. How am I doing? Okay, last decision point. Does this child require admission? Okay, so this is sort of, this decision, if you look at the British guidelines, this is the single most important decision that we make as ED clinicians for pneumonia. Why? Because this decision is what drives costs in this disease. This is what makes pneumonia care the second most costly disease in the United States. So, here are the hospitalization criteria that the IDSA recommend. Moderate to severe disease, which I'll define on the next slide. Kids less than 3 to 6 months of age, where you've got a focal infiltrate or they look sick, you suspect a bacterial pneumonia, those kids should come into the hospital on IV antibiotics. They're too young and they can decompensate way too quickly. If you suspect an organism with increased virulence, so MRSA, and when would you suspect that? Well, if they had a large whopping abscess, a few weeks earlier, that might clue you in. If it's multifocal, if you see an effusion, if you see necrosis, if you see an abscess, all those kids need to be brought into the hospital on MRSA covering antibiotics. And then if you have concern about follow-up or care at home. So how does moderate to severe disease defined? So that's tachypnea for age, 60, 50, 40, 20, dyspnea, retractions, and I would say not just, a little tugging, a little subcostal. These are moderate to severe retractions, subcostal, intercostal, suprasternal, okay? Grunting, nasal flaring in the infants less than 12 months of age, apnea, altered mental status, and that's not just the tired appearing kids, that's truly altered mental status, and a transcutaneous oxygen saturation of less than 90%. That's how we would define moderate to severe disease. Now keep in mind, this is all based on sort of pulling adult guidelines and it's sort of weaker evidence. This is a suggestion from an expert panel. So what we still have to do in pediatric pneumonia is actually define moderate and severe disease based off of outcomes. And that's sort of the major thrust of the work of our team that we're trying to do right now is to help risk stratify these kids. So who needs intensive care? Well, part of this is depending on your institution about what you handle on the floor versus on the intensive care, in the intensive care unit. So if you need positive pressure ventilation, I would define that as high flow nasal cannula, BiPAP, CPAP, and obviously mechanical ventilation. If you feel like there's signs of impending respiratory failure by blood gas or by clinical signs and symptoms. Sustained tachycardia, hypotension, or need for pharmacologic support of the blood pressure, that's kind of a duh factor. Oxygen saturation of less than 90% on an inspired fraction of oxygen greater than or equal to 50%, and altered mental status. So, with that, my take-home points are combinations of clinical signs and symptoms are more useful than isolated findings. Fever, SATs less than 92%, tachypnea, focal RALs. That combination, that sort of quartet of signs and symptoms are going to be sort of your key to the clinical diagnosis of pneumonia. Chest x-rays are most useful in moderate to severe disease, failure of initial therapy, or complications. If you are fairly certain in your clinical diagnosis and the kid is well enough to go home, you don't need that x-ray. There's little role for laboratory testing in mild to moderate disease. Again, the exceptions are flu tests during flu season and blood cultures in the kids that you're hospitalizing with moderate to severe disease. Amoxicillin and ampicillin is the treatment of choice in most cases. Just out of curiosity, what do you guys go to for first line here? Outpatient? For inpatient. Ampicillin. We changed over. Love it. Good. And then azithromycin should generally not be used as empiric monotherapy in pediatric pneumonia, but you should combine it with the beta-lactam. And with that, I will say thank you, and I'm happy to take any questions.